Good morning, good evening, and good night from everyone from across the globe that's joining us for this edition of the EIOC Journal Club. Today we'll be talking about the management of patients with advanced breast cancer post-progression on CDK4/6 inhibitors. My name is Shaheenah Dawood, and I'm a consultant medical oncologist coming to you all the way from the very sunny, very bright, and very warm but very safe United Arab Emirates. And I'm joined today by spectacular faculty, both locally, regionally, as well as internationally. And I want to first introduce Javier Cortes, who is a personal friend for, I think we're growing old together, Javier, don't you think? For almost 15 years. I'm going to let you introduce yourself, Javier.
True, it's a great pleasure to be with you all. And Shahina, thank you very much for inviting me to be here with you. And, yeah, we know each other for more than 15 years, but at that time, you were almost like a baby. I was old that time. So, but yeah, many years together.
Ahlam.
Yeah, yes. How are you all?
Hi.
And good morning, all. I'm Dr. Ahlam Yusuf. I am consultant medical oncology in the National Center of Cancer Care and Research in Qatar.
Mohammed.
Yes, hi everyone. Good evening. I'm a medical oncologist from Tawam Hospital, UAE.
Dr. Nouri Bennini.
Hello, everybody. Dr. Bennini, consultant oncology in Tawam Hospital.
Dr. Ram.
Hello, consultant medical oncologist at Mediclinic Abu Dhabi, United Arab Emirates.
And Dr. Sahar. Is she here? So, yes, she's here. Please, you're muted, Dr. Sahar. Yes.
Yeah, sorry. I'm a medical oncology consultant in National Oncology Center, Royal Hospital in Oman.
So you can see we have a very diverse faculty group over here. So it's going to make some very interesting discussions today. So let's just look at the agenda very quickly. If we can go to the next slide. So we're going to start off by Javier actually walking us through the updates on advanced management of patients with metastatic breast cancer post what we know is the best line therapy in the first line therapy with CDK4/6 inhibitors. Specifically focusing on those patients who've got alterations in that AKT pathway and beyond. After that, we're going to have a very fiery discussion with everyone on the panel today. Specifically, Javier, I apologize, but I am going to pick on you today. And we're going to try and answer those pertinent questions that we as medical oncologists need to know in the community. So Javier, take it away with the updates.
Thank you very much, Shahina. Let me share my slides. Just one second. Okay, can you see my slides?
Yeah, it's coming up. It's coming up. Yes, now we can see it.
Okay, brilliant. So again, Shahina and Fox, thanks a million for this time together. Unfortunately, in a virtual way, but always a pleasure, always a pleasure being with you. So today we are going to discuss about how to treat our patients in clinical practice when they have received and progressed on CDK4 and 6 inhibitor-based therapy. And as Shahina pointed out, we will basically dive into the AKT pathway. So how to treat patients when the tumors upregulate the signaling pathway. So these are my disclosures. And this is where we are coming from. I think that we all agree that in general, we like to treat our patients with CDK4 and 6 inhibitors plus either ROT inhibitor or fulvestrant, depending on if this is a second line or first line. But it is true that there are some patients, maybe some frail patients, or maybe very old, or some specific situations where in the postmenopausal status, when we can discuss about the SONIA strategy, which is starting with endocrine therapy only, followed by CDK4 and 6 inhibitors in the second line setting. But for the great majority of our patients, I think that we all agree that CDK4 and 6 inhibitor-based therapy is the best way to treat them. So what to do afterwards? We have a patient who has experienced progressive disease after CDK4 and 6 inhibitors plus endocrine therapy. And let me start with some data about CDK4 and 6 inhibitors after CDK4 and 6 inhibitors. And we have 4 randomized trials, 3 randomized phase 2 trials, and 1 randomized phase 3 trial. This is the 3 randomized phase 2 studies. You can see here the maintain and Palmyra. Maintain is not really maintained. It's like change, because the majority of these patients received palbociclib in the first line setting and were randomized to receive either endocrine therapy placebo or endocrine therapy plus ribociclib. So we basically change from palbo to ribo. And there is a very beautiful signal, has a ratio of 0.57. Small piece of data, 119 patients in total, 60-60 more or less, but a clear signal. Based on Palmyra, basically explore palbo after palbo. And palbo after palbo clearly does not work. There were not advantage at all giving palbociclib in patients who progressed on palbociclib before. And this is the only randomized phase 3 study exploring CDK after CDK. These are basically phase 3, fulvestrant placebo, fulvestrant abemaciclib in patients who received and progressed on CDK4 and 6 inhibitors before. About 65% of patients received palbo, about 25% received ribo, and about 10% received abema. Investigator assessed PFS was the primary endpoint, and we can see here 3 things. First one, the trial met the primary endpoint. So abema fulvestrant was superior to fulvestrant palbo according to a primary endpoint. Second comment, the benefit was modest. You can see here that the improvement, the absolute improvement in the median PFS was 1 month, from 5.3 months with fulvestrant placebo to 6 months with fulvestrant abema. But when we looked at the BCAR assessed, so the blinded assessment, we observed that the hazard ratio was better and the PFS improvement was higher. So maybe, in my opinion, for those patients who are on treatment for CDK for a long period of time and maybe develop oligoprogressive disease, maybe we could discuss continuing with abemaciclib in the second line setting. That's something that we could discuss afterwards. Now, the point is how to deal with endocrine resistance. So can we understand why the tumor was resistant to endocrine therapy? And there are basically 3 different mechanisms of resistance. This is the one of the most important ones, which is the ESR1 mutation, when the resistance is basically not driven only, but also it's basically driven by the estrogen receptor. For example, ESR1 mutations. In the ESR1, the receptor is insensitive to estrogens, and this receptor is active regardless if we have estrogens or not. Second, when the resistance is driven by the estrogen receptor, but not only. We have other resistant pathways. For example, here when we have PIK3CA pathway alterations, the resistance is not just because of the estrogen receptor. We need to block something else. And 3, when the resistance is not driven at all by the estrogen receptor. And here we have the example of when we get a biopsy, and the biopsy reveals ER negative, PR negative. So these tumors become insensitive to the endocrine pathway. So again, as I said before, ESR1 mutations or PIK3CA alterations are some of the examples of these mechanisms of resistance. So if we are able to understand the mechanism of resistance, we will be able to treat these patients accordingly. Let's start with the ESR1 mutations. How frequent are they? So at the very beginning, when the tumors were not exposed to endocrine therapy, these mutations might exist, but they were very undetectable. We detect these mutations only in about 3 to 5% of all patients. However, when the patients were exposed to aromatic inhibitors, maybe under a clonal pressure, we might upregulate, we might see more clonal cells that are resistant to aromatic inhibitors. And one of the mechanisms here is the ESR1 mutation. So we check the ESR1 mutations in the second, third line or beyond. We can detect about 30 to 40% of these patients having these mutations. How can we treat these mutations? So basically, aromatase inhibitors will not be ideal because, as I said before, even if you don't have estrogens, this receptor might become active. So we have to block the receptor with the SERMs, like tamoxifen, with the new SERMs, with the Protex, with the SERMs, with the SERCAS. In other words, all these drugs try to down-regulate, try to destroy the receptor. So if we destroy the receptor, this might work. So let's go to the clinic. What are the data we have with the oral search in the clinical setting? And let me start with the Shaheenah 6 study, just one or two slides. Remember, in Shaheenah 6, patients were receiving CDK4 and 6 inhibitor plus letrozole, and we just looked at the ctDNA. When we detected ctDNA increase based on the ESR1 mutation, means that at this time, the tumor is starting to become resistant to endocrine therapy. So the investigators did this randomized phase 2 trial to continue with letrozole and CDK, or changing from letrozole to camizestrant and Ulcer, and continuing with the same CDK. And you can see here the beautiful results. PFS improvement from 9 months to 16. The time to deterioration in quality of life also much better, and PFS2 was also superior. So if we detect that something is wrong and we detect this mutation, maybe this early change could improve outcomes. Now, let's continue with the classical studies. So after CDK4 and 6 inhibitors, we detect the progressive disease and we see mutations in the ESR1. And we have 4 randomized phase 3 clinical trials. The Emerald, it was conducted in the ITT, but I was referred to those patients with mutations in the ESR1. You can see here the hazard ratio, 0.55 in favor of elacestrant compared with sham choice. And which is very interesting, when we looked at those patients who benefited from CDK in the first line setting and were free of progressive disease for at least 1 year, these patients did have a median PFS with elacestrant for 8.6 months single agent. So these are the patients that, these are the tumors that might become resistant just because of the ESR1 mutation. So if we block that mutation, if we go for an ulcer, we might have great activity. Second study, beta-2, vepdegestrant versus fulvestrant. Vepdegestrant is a PROTAC. PROTAC is a drug that basically has like 2 arms. One arm binds the estrogen receptor, the other arms binds the proteasoma. And what we are doing is to put together the estrogen receptor and the proteasoma, and the proteasoma destroys the estrogen receptor. Okay. So vepdegestrant compared with fulvestrant, identical results. In the ESR1 mutant population, hazard ratio 0.57, 0.55 with elacestrant, 0.57 with vepdegestrant. Again, in all comers, in the wild type, this was not superior to fulvestrant. Third study, number 3, imlunestrant, another oral SERT. So imlunestrant compared with fulvestrant or exemestane. Once again, in the ESR1 mutant population, hazard ratio 0.62 in favor of imlunestrant. In this study, we also explore imlunestrant plus abemaciclib compared with imlunestrant. This trial is a little tricky because many of these patients did not receive CDK4 and 6 inhibitors before. So, I don't know how to interpret imlunestrant plus abema versus imlunestrant in the wild-type patient population. So, in my opinion, or elacestrant, or vepdegestrant, or imlunestrant in the ESR1 mutant population, these 3 drugs are good options, better compared with the standard of care. And finally, there is a beautiful study called EVERA, which explored the doublet. So the standard of care was either tamoxifen, fulvestrant, or exemestane plus everolimus for a significant number of patients, and we compare versus giredestrant plus everolimus, the oral served by Genentech and Roche. And you can see here the beautiful results. Wow. Giredestrant everolimus has a ratio 0.38 in the ESR1 mutant population compared with standard of care endocrine therapy plus everolimus. In the ITT, 0.56 has a ratio, and in the wild type, there is a signal, but the hazard ratio crossed the 1. So in my opinion, once again, these drugs are for the ESR1 mutant population. Beautiful data in terms of overall survival, although immature. So what have we learned? If we get a biopsy and we have a mutation in the ESR1, we have different drugs which might be superior to endocrine therapy. Now, what happens if we have a mutation in the PIK3CA AKT mTOR pathway? So what do we have regarding the phase 2 trials blocking this pathway? Let me start with the old studies. Bolero, basically exemestane everolimus, an mTOR inhibitor, exemestane placebo, in the pre-CDK4 and 6 inhibitor time. Nevertheless, beautiful hazard ratio 0.45. Second study, SOLAR-1, with alpelisib, a PIK3CA alpha inhibitor. In the PIK3CA mutant patient population, fulvestrant alpelisib, fulvestrant placebo, once again, superiority for the pathway inhibitor, alpelisib. And the most modern study, Capitelo 291, is with capivasertib fulvestrant, placebo fulvestrant. Capivasertib is an AKT inhibitor, so I will go back to this trial in a minute. Finally, we have the last randomized phase 3 study, in my opinion, with great interest, which is INAVO 120. In INAVO 120, patients who were resistant or refractory to endocrine therapy in the early breast cancer setting and did have a mutation in PIK3CA were randomized to receive either fulvestrant palbo or fulvestrant palbo plus inavolisib, another PIK3CA inhibitor by Roche Genentech. Look at here the data. PFS with the doublet, just 7 months. Resistant to endocrine therapy and PIK3CA mutation. When we combine with inavolisib, 17 months. Also improvement in time to the first subsequent chemotherapy, and which is very, very interesting, improvement in the overall survival from 27 months to 34 months. 7 months absolute improvement in overall survival. We have 2 more phase 3 trials that for me are less important, which is Victoria 1, study 1, and Victoria 1, study 2. Those studies are with geratolisib. Geratolisib is a dual mTOR and PIK3CA inhibitor. This drug is intravenous infusion, is IV infusion, on day 1, 8, and 15 every 4 weeks. This drug has a lot of stomatitis, reflecting that maybe this is more mTOR inhibitor based than PIK3CA inhibitor based. In the study 1, patients with PIK3CA wild type were included and received either fulvestrant alone, fulvestrant gerato, or fulvestrant gerato plus palbo. Very importantly, in this trial, patients could have received and progressed on fulvestrant before. And many patients received fulvestrant and progressed on fulvestrant before and were randomized to fulvestrant. So it's like a placebo for many patients. That's why the hazard ratio was so impressive, 0.24. In my opinion, this is not correct because, again, many patients in the control arm were received fulvestrant before. And study 2, same strategy, but in the PIK3CA mutant population. And the control arm here was fulvestrant and alpelisib. Look at here that when we compare fulvestrant alpelisib with fulvestrant gerato or fulvestrant gerato palbociclib, gerato plus fulvestrant was superior to alpelisib fulvestrant. Let's explore in more detail this pathway, the PIK3CA KT mTOR pathway. So this pathway is key. Is key in tumors because this involves proliferation, metabolism, cell survival. So many of our tumor cells do depend on this pathway to survive, to proliferate, to grow. So how is it possible this pathway to become active? There are three different mechanisms. The first one, when we have specific alterations in this pathway, in other words, mutations in PIK3CA, mutations in AKT, alterations in PTEN. So if we do not, or these proteins do not work well, this pathway is active. But also, we may have these proteins, these genes, this pathway normal from the structural perspective, but it can become active by two other mechanisms. One, when we have activation of the membrane receptors. For example, HER2. When HER2 is amplified, this pathway is active. As a mechanisms of resistance to endocrine therapy. When we block the endocrine pathway, we upregulate this PIK3CA AKT pathway. So even though, and you can see here, even though we do not have alterations in the pathway such as PIK3CA or AKT, we can see that in tumors which are resistant to endocrine therapy, we observe an upregulation of this pathway. So again, three different mechanisms of activation of the PIK3CA pathway, which might explain also why these pathway inhibitors work regardless they have mutations or not. What is Capiva? So Capiva is an AKT inhibitor. And why am I going to spend more time about Capiva? You might say, why? Because this is an AKT program. No, it's not that true. So basically, because when you look at the activity of alpelisib, everolimus, Capiva, is not that different. However, the toxicity profile is. However, patients who discontinue the treatment because of everolimus or because of alpelisib is two times higher compared with Capiva. So the toxicity profile is much better. That's why the preferred option for many of us is Capiva compared with alpelisib or compared with everolimus. Okay, so how many tumors do have alterations in this pathway? 50%. So 40% mutation in the PIK3CA, 5% mutation in AKT, 5% alteration in the PTEN. Now, is it possible to have co-mutations, ESR1 and the PIK3CA AKT pathway? Of course, yes. At the very beginning, it's very infrequent because ESR1 mutations are very infrequent, but in second, third line, they might become more and more frequent, and up to 20 to 30% of patients could have co-alterations in these two pathways. And sometimes it's not just two mutations. Sometimes we have many mutations, even 3 or more mutations. So how to deal with these patients? How to treat patients with these dual mutations? I'll make some comments in a minute. Finally, a PIK3CA is a very stable mutation. Usually, when it exists from the very beginning. PTEN could be an acquired alterations. And of course, ESR1 is an acquired or a subclonal alterations. Now, why to test, whom to test, when to test, and how to test? In my opinion, I would summarize in 3 comments. The first one, how to test. If possible, NGS. Why? Because it will give us not only the PIK3CA mutations, also PIK3CA, AKT, ESR1, etc. Second, why to test? Because we have drugs that could help our patients if they have these mutations. And when and whom to test? Always if we have clinical studies or when we have drugs available to treat our patients accordingly. If we are unable to treat these patients with these drugs and we don't have clinical trials, why do we have to do this test? So that's very important because it could produce frustration to patients. Imagine that you have a PIK3CA mutation, but we cannot do anything against that. Why do we need to know this mutation? No. Go to Capitello 291 in the last 10 minutes or so. Capitello is a randomized phase 3 study. Fulvestrant placebo, fulvestrant Capiva. Remember, Capiva, 4 days treatment, 3 days off. It is not a continuous drug. 4 days on, 3 days off. Very important. 4 days on, 3 days off. In this trial, patients received at least 1 prior line of therapy in the metastatic setting, but not more than 2. And patients could receive up to 1 prior line of chemotherapy in the metastatic setting. CDK was allowed and required for at least 51% of patients, but it was not mandatory. Dual primary points: PFS in the ITT in the overall patient population and PFS in the PIK3CA altered population. Alters mean PIK3CA mutation and or AKT mutation or an PTEN alteration. Look at here. 70% of patients received CDK4 and 6 inhibitors. Second, the great majority, 80% of patients, were treated in the second line setting. And now 20% of patients, roughly, received chemotherapy in the metastatic setting. Such. Both co-primary endpoints were positive. Clearly, significantly positive. Look at in the ITT, hazard ratio 0.60. In the PIK3CA altered population, 0.50. In the wild type population, 0.70. Based on this data, the drug has been approved for the PIK3CA AKT PTEN altered population. What about overall response rate? In the altered pathway, 10% with fulvestrant, 30%, 28.8% with fulvestrant plus Capiva. Subgroup analysis, you can see here that all patients benefited identically. Hazard ratio again in the range of 0.50. Now, what about PFS2 or time to the first subsequent chemotherapy? These were the first data, and this was the updated data. PFS2 has a ratio 0.68. Time to the first subsequent chemotherapy has a ratio 0.62. When we use fulvestrant, the median time to 6 months to start chemotherapy. When we use fulvestrant plus Capiva, 11 months. Overall survival was immature. Nevertheless, look at what happened in those patients who received CDK4 and 6 inhibitors before, 70% of the patient population. There was a clear signal. Hazard ratio 0.78, moving from 21 months to 28 months. 7 months absolute improvement in overall survival. This is a very interesting slide, just highlighting that the subsequent lines of therapy was imbalanced according to the fulvestrant placebo or to fulvestrant Capiva. That also might explain the survival data. One other important study. What happens in terms of PFS for those patients who received treatment in the second line setting after CDK, just second line. PFS moving from 2.6 months to 7 months, hazard ratio 0.50. Once again, the absolute numbers are more beautiful in the second line setting, but the benefit was the same. And look at this data compared with Emerald, Serena, Ember3, etc. With these drugs, we have about 40 to 50% of patients who experience progressive disease very early on time. When we block the pathway, the PIK3CA pathway, we observe that these 20% of patients continue to progress very quickly, but the other 30% of patients who progress quickly with endocrine therapy, we can delay the resistances of these patients. That's why we also might prevent these early progressors. What happens when we have co-mutations in the ESR1 and in the PIK3CA? This data come only from the real world data, showing that, for example, elacestrant works, but the absolute benefit is clearly lower in the PIK3CA mutant tumors compared with the PIK3CA wild type. So when to decide elacestrant or camizestrant or imlunestrant or belgestrant compare with Capiva? In my opinion, it will depend on the time to disease progression. So if the tumor is controlled for 3, 4, 5 years, if we have a co-mutation, maybe PIK3CA is not a driver, and maybe ESR1 could be a driver there. And the other way around, if we have a patient who start with CDK and has progressive disease in 7, 8 months, 12 months, 14 months, the PIK3CA is a driver there. So we might block the PIK3CA pathway much better. Look at this data again, comparing Polero, Solar, Capitello, similar data in terms of the benefit. Hazard ratio 0.43, 0.65, 0.50. But look at also here the discontinuation rate. Clearly better with Capiva, which reflects the toxicity profile. It's 25, 30% with Bolero or with Solar-1 compared with 13% with Capitello. Which are the most important adverse events with Capiva? Basically, gastrointestinal adverse event, rash and hyperglycemia. Diarrhea, 70%. Grade 3, 10%, 9.3%. Other adverse events were much more infrequent. Hyperglycemia, 16%, much better than alpelisib, and 2% grade 3. And rash, 22%, grade 3, 5%. So I think that it's a nice drug to be used in terms of adverse events. Finally, I wanted to share another randomized trial, the FINER trial or MA40 trial conducted in Canada by Stephen Kia, led in Canada by Stephen Kia and Fox. This is basically the same strategy, fulvestrant placebo or fulvestrant ipatasertib, the AKT inhibitor by Roche, exactly the same results. Hazard ratio 0.61 in the ITT population, hazard ratio 0.47 in the AKT pathway cohort. So, in my conclusion, CDK4 and 6 inhibitors continue to be the standard of care in the first line setting. In the second line, we should think about biological driven strategy, and Capiva here might play a significant role. Why? Because also with alpelisib, also with everolimus, it clearly improves progression-free survival. It improves the outcomes of our patients, but the safety profile, in my opinion, is much better. So, friends, colleagues, I go back to you and Shaheenah to continue the leadership of this meeting. Thank you very much.
Thank you, Javier. Excellent as always. I am just going to share my slides. So just give me that 1 minute to pull them up. Can everyone see my slides?
No, actually, yes, now.
Yeah, okay, perfect. So I'm just going to put it on full screen. So Javier, since you set the stage for everything, I think the arena of hormone receptor positive, HER2 negative metastatic breast cancer has become, I think, even more complex than any other type of breast cancer. I'm only talking about breast cancer, but I'm also going to maybe put that statement out there and say that, lung cancer used to be the poster child of precision medicine. I think HR positive disease is now the poster child of precision medicine in the realm of breast cancer. So my question to you, Javier, is, should every patient at the time of diagnosis of stage 4 disease or recurrent disease have comprehensive profiling of their tumors?
That is a good comment. So I think that the honest answer is it depends. It depends. So my first question is, are we going to treat the patient according to the results of the NGS? If the answer is yes, based on a clinical trial, based on a targeted therapy, whatever the reason is, but if we are going to treat the patients accordingly, definitely yes. So in my opinion, if we have a patient who is resistant to endocrine therapy, we have inavolisib there with very good outcomes. So the answer is go for that. If we have naive patients or endocrine sensitive tumors, if we do not have clinical trials, I think it is not needed because we have not seen that in this patient population, blocking the PIK3 pathway is or will be the standard of care. We have to wait and see the Capitello 292 with Capiva, or we have to wait the Inavo 123 with inavolisib. So we have to wait and see. So in my opinion, it depends on the treatment we will decide according to the data we have.
So Javier, I hear what you're saying, but I respectfully disagree.
So I
And
love
the
that.
reason why I would disagree is that I personally feel that every patient, whether recurrent or de novo, endocrine sensitive or endocrine resistant, should have at the time of diagnosis full profiling of their tumors because PIK3CA and a lot of these mutations are actually there right from the very beginning. And we don't know the natural history of the diseases at the time of recurrence. It's only something that we learn as we are treating those patients. So the way I see it, and again, I could be completely wrong, but the way I see it, it's good to have that information up front because should your patient start to progress very quickly, at least you have that information to be able to target that PIK3CA pathway and not wait the 2 to 3 weeks it sometimes takes just to find out those biomarkers. You can counteract, Javier. I'd love to play devil's advocate over here.
I love you. I love you. Okay. So no. So listen. Next time you say, "Well, I want to be prepared to treat my patients as soon as possible afterwards if needed," and that's totally fine. That's totally fine. The point is that at least in Spain, we cannot do a lot of NGS over time, and for example, that the ESR1 will appear afterwards and not from the very beginning. But the answer is, of course, if you can do it afterwards again, that's brilliant. But it will not change the first line. Maybe you will be able to rush a little bit afterwards. That's fine.
So, Mohammed,
Shaheenah,
I think
can I get an opinion?
I'm coming to you, Dr. Bennini. Don't worry, I'm coming to you.
Because
Javier can't disagree with me because we'd fight offline. But I'd like to hear Mohammed's thoughts first in terms of when do you profile, and then I'm coming to you, Dr. Bennini. Give me 1 second.
Yes, Dr. Shaheenah. I think I agree more with Dr. Cortes. I believe if we are not planning or if we don't have an action as a general idea in all medicine, if I'm not planning to treat, why I will investigate? It's good to have, as you said, in advance to have the results. But again, you need to check the ESR1, which is usually acquired, and you need again to repeat the test on the progressions. So if I'm going to repeat the NGS again, why I will do it one time on a progression, looking for the whole results.
Okay, Dr. Bennini, your colleague has just disagreed with me. Are you going to disagree with me now?
Yes, sure, I disagree with you.
Oh my God!
Because simply not all of us work in a plethora where access to the NGS is so easy.
That's true. That's true.
Yeah, not all of us. So I would agree with you only in the case if the tumor is a hormone resistant from the beginning. That means it's already the patient is on adjuvant treatment is with progression with less than 1 year on adjuvant treatment. At that time, yes, I would, because I consider from the beginning as resistant. It might be interesting, but in a patient who progress or de novo metastatic without any sign of hormone resistance, I would prefer to wait until the next progression, because simply, even if you do it as early as you want, as you said, you'll have to do it again at progression. That's
I agree with you.
The sense of my opinion.
I agree with you, Dr. Bennini. Let me see if I can change Dr. Ahlam's mind here. So I recently had a patient, it's not recent, it was about a year ago, a young lady, 37 years old, who came to me with hard rocks on both her breasts. Both her breasts were completely engulfed with cancer. I biopsied it. It was an ER/PR positive, strongly so, HER2 low, and a low Ki-67. She'd ignored the tumor for many years. And when I staged her, she had extensive liver metastases. So this was a stage 4 de novo disease. I
Yeah.
profiled the tumor. I started her on a CDK4/6 inhibitor plus endocrine therapy. After a quick initial response in the first couple of months, I started to see things grow on her chest very, very quickly.
Oh.
Now, at that point, I took another biopsy, I did a liquid biopsy as well. I sent it off to profiling, but she was progressing a little bit, faster than I would like. Still,
Yeah.
I was actually wanting to give chemo, but she didn't want chemotherapy because she was progressing on a slightly faster path. But I had the results of my first profiling that said she has a PIK3CA mutation, and I immediately shifted her over to fulvestrant and capivasertib, not waiting to
Yeah.
see if she has an ESR1 mutation, which was unlikely because, she'd progressed so
The
quickly.
rapid
She
progression, yes.
actually responded. So now I want you to tell me, when do you profile your tumors?
When we profile our tumor, yes, in the first progression. I agree with the group, Dr. Shaheenah.
Lone Ranger here, Javier, everyone's with you right now.
Yeah, actually, unless I wanna consider inavolisib, I will not go to do the testing unless after the first progression. And yeah, I'm happy for your patient that she had a response for Capi, but she stayed on Capi for how long, if you remember the story?
So she stayed on Capi for about 5 months.
5 months, yeah.
Yeah, then I had to shift her over to TDXD, yes.
Yeah, I
Because
agree.
she had HER2
Okay.
low disease.
Yeah,
So,
okay. I agree.
all right. So, Dr. Sahar, let's go over the first point that Javier actually brought up, and that is the role of using a CDK4/6 inhibitor beyond progression of disease. Have you done it beyond progression of disease? And if so, what are your criteria to use a CDK4/6 inhibitor beyond progression of disease? I can tell you I do it a lot.
For me, I didn't do a lot.
Oh my God,
Uh,
nobody's
be-
agreeing with me today. Javier, you need to support me.
maybe in one situation I may consider, but as mentioned by Professor Cortes, the benefit is modest, maybe except for the post monarchy. However, I may consider for those patients stayed for a long time on CDK4/6 inhibitor, maybe years, and then for any reason they progress, but uh, some sort of not a frank disease progression, mixed response, I may consider to change the CDK4/6 inhibitor together maybe with changing also the AI to fulvestrant. So because of the treatment exposure may be long on the CDK4/6 inhibitor, I may give her the patient another chance with CDK4/6 inhibitor. Otherwise, if the patient progressed rapidly on CDK4/6, how can I expect from CDK4/6 inhibitor after this rapid
That's a
progression?
fair point. That's a fair point. The reason why I do a lot of CDK4/6 beyond progression of disease is because I don't believe in using endocrine monotherapy. So in patients who don't have an abnormality in the AKT pathway, I tend to combine fulvestrant or an oral SERD with a CDK4/6 inhibitor. Now, with the newer data, I may even think about everolimus, but I don't find everolimus to be a very easy drug. And that's the reason why I do a lot of CDK4/6 inhibitor beyond progression of disease. Javier, what are your thoughts here?
I think you raised a great comment, Shaheenah. I couldn't agree more. I think that you are totally right. So there are like 3 groups of patients broadly: the ESR1 mutations, the PIK3CA mutations, and patients with wild type for both. And I think that here, certainly, these usually are patients who stay long under CDK, as Dr. Sahar said before. So there are certainly patients there that could benefit from continuing CDK4/6 inhibitor. I would agree.
Okay, Ahlam, what are your thoughts here?
Yeah, I agree that combination of CDK4/6 after CDK4/6 is there, post-Monarch trial is there, and now we have the new data of elacestrant and Elevate trial and combination of elacestrant with APEMA. Yeah, I saw one of the patient started here in our center. She is not typical the criteria of this trial. But yeah, it is better. We are in the era of the combination of the medication for this
For sure.
population.
For
And I
sure.
think, yeah, this will delay significantly the need for the chemotherapy.
So, Dr. Ram, let me ask you the next question. How do you actually test for these alterations in the AKT pathway? What is your methodology of testing?
Okay, so we now understand that for most of the patients, the testing should be at progression after CDK4/6 inhibitors. So these patients, the best way of testing is to identify the acquired ESR1 mutation is a liquid-based testing. So it's mostly it is if the solid tissue is available and on the liquid, if it is negative, because these mutations can be identified easily and it is a less invasive procedure. But if we have a solid tissue also, if the liquid doesn't show, especially certain mutations like P10 are more identified. Little excess numbers are identified by NGS testing of the solid tumor. So I utilize both methods. But in the post-progression, I would first lean on towards the liquid biopsy to test for these mutations, which in majority it will pick up.
So, Javier, at San Antonio last year, we saw some very interesting data from Capitello that looked at the tissue pickup rate for AKT alteration and the liquid pickup rate. And if I remember correctly, 10% of patients actually had an alteration picked up on a liquid, but not on tissue. So if your tissue is negative, should we be doing a liquid was my first question, or should we be just doing it together right from the very beginning? Because we know that in the realm of lung cancer, that's what we're doing. We know in the realm of colon cancer, that's what we're doing. There's more of a push to do liquid and tissue at the same time so that you don't miss anything. What should we be doing in breast cancer?
I think it's an extraordinary question, Shaheenah. I don't have a clear answer here. Because, of course, at least in many, many countries, it's impossible to go for both. So the answer is I would love to do it because it is absolutely complementary. So PIK3CA is better in the solid, but maybe SR1 is better in the liquid. But in the real world setting, it's not possible to do it in both every time. So sometimes we can do it sequentially. Sometimes. What we can do sometimes is to go for a liquid, and if it is negative, we just go for the PIK3CA only in the tumor, or the other way around. We go for an NGS in the solid, and if it is negative, we can go for just ESR1 in the liquid. But NGS is both. I would love to do it. The answer is yes, do it if possible, but certainly we cannot do.
Dr. Nouri, what would you do in your clinic? How do you test for PIK3CA? Dr. Bennini?
Yes, I'm with you. Actually, we have the test covered by the company, so we are doing it regularly at progression on liquid basis. Even though I have once I had a patient who was negative on liquid biopsy and was positive on the tumor. So this make me sometimes when I have a patient who is negative in blood, and I can even repeat the test because sometimes there are some problems with the labs. So because over the last 2 years, we had many labs the change, and we have to check on the quality of the NGS itself, definitely.
So, Dr. Mohammad, how do you test in your clinic?
So actually, I prefer the liquid test. It's considering the heterogeneity of the disease. Actually, it's fast test, and As Dr. Cortes said, it's difficult in most of the time to do both of the tests. So the preferred for me is the liquid. If it's come negative and I still has high suspicious, I will do after that the tissue, considering that sometimes it may come negative if we have low tumor fraction in the liquid. And as Dr. Bennini, we have a few cases that it's come negative in the liquid but positive in the tissue.
Absolutely. All right, so let's go on to some of these case studies. So the first case is of a 35-year-old lady. She's married. She presents with stage 4 de novo disease, liver mets, lung mets, bone mets. Biopsy is sent for profiling because, she's my case and I profile everyone at the time of diagnosis. And she's found to have a PIK3CA mutation and she's truly HER2 negative. She's commenced on a CDK4/6 inhibitor plus an AI plus ovarian function suppression. Her PFS is 14 months. A liquid biopsy is done and now an ESR1 mutation is detected. She's progressed in the liver and bone, but there is no crisis actually. So you have the opportunity to change endocrine therapy. So Javier, here you have a patient and you discussed it very well, co-mutation. My first question is, before you tell me what you would prefer to target, my question to you is, does the variant allele frequency of the two targets actually play a role in your consideration of what you're going to target?
Oh, first of all, co-mutations in this second line in this case, could be in the range of 15-20% more or less. Okay. Second comment: this is a patient with liver metastasis from the very beginning. This is a patient with a 14 months, which is not bad for a PIK3CA, but it's not a lot. I think this is a PIK3CA driver mutation here. I don't like PIK3CA here. So here I would prioritize blocking the PIK3CA pathway than blocking the ESR1 pathway. So for me here is Capiva more importantly than the other search.
So what sort of PFS would you want to see before you say, okay, I may consider the ESR1? Because in Emerald, I know that they had that cutoff of beyond this cutoff, you can use ESR1, but it was a post hoc analysis. And it's never been replicated. So I don't even know whether this is true or not. So you tell me what PFS you would be comfortable with.
A lovely question, Shaheenah. It's a lovely question. I like the 12-month cutoff, and I will tell you why. Because, for example, in the Parsifal, remember that was in the first line, fulvestrant palbo, Letzor palbo. We observed that patients who stay on the treatment for more than 12 months clearly behave much better in terms of overall survival compared with less than 12 months. 12 months was the cutoff. We compared 0 to 6, 6 to 12, more than 12. 12, 18, 18, 24, more than 24. 12 months was the optimal cutoff. Now, second, here is true that 14 months is more than 12 months, so maybe LSSM could be out option. Actually, yes, if the PIK3CA would have been negative. The point here is that we are in the limit, 14. We have liver metastasis. We have a double mutation. So if I have to decide based on the time, which is more than 12, but it's just there. It's not 24, 34, or 44. It's almost there. Liver metastasis. I feel more comfortable blocking PIK3CA.
Okay, Dr. Ram, what are your thoughts here?
Yeah, I think I would be more inclined towards doing a combination. So taking that into a factor, fulvestrant and Capiva would be the preferred first choice for me. But now we have also data coming up, although from a smaller number of patients, is what was mentioned by our panel member about the ELEVATE study, where LSS strength can be combined with we have the option of giving another CDK4/6 inhibitor or everolimus, or even giving for these patients capivasertib. So maybe that is also an option for me. But if it is in the guidelines, I will be supported and get an insurance approval for that. And we know how to manage the toxicities of each of these drugs, because we have used Capiva. If we want to use LSS strength plus Capiva, we have used it, so we know it.
Yeah.
So I can tell you that at least for me in 2026, I will not use monotherapy endocrine therapy. I believe it needs to be combination. And in a patient like this, I agree it needs to be combination. So this is the second patient. This is a 55-year-old lady. She's got recurrent breast cancer. Tissue profiling is done. First line, she receives CDK4/6 inhibitor plus endocrine therapy. Her PFS is 15 months. Sites of progression are the bone and the lung, and a liquid biopsy shows an ESR1 mutation. Now, before we go on to what we would do in the second line setting, you can see liquid biopsy did show an acquired ESR1 mutation, and her initial NGS showed that she had an AKT alteration. She's also got a HER2 low disease. My question to you, Javier, is I know INAVO looked at only patients with a PIK3CA mutation, but in a patient with an AKT alteration as well, are you comfortable giving only CDK4/6 plus an AI upfront and not targeting that pathway? This is just a hypothetical question. We have no data in that line setting, but what are your thoughts here?
No, I don't feel comfortable at all. I would love to give Capiva here in the first line setting. Absolutely, yes. But we cannot do it. So INAVO will not work here. INAVO blocks upstream, so it will not help. But we cannot use Capiva, of course, in this setting. But I would love to combine Palvo, letrozole plus capivasertib. That's what I would love to do. If not, AI CDK first, and let's see afterwards.
Perfect. My second question to you, Javier, is we didn't touch upon the topic, but FDA gave approval for CAPI within the realm of alterations in the AKT pathway. Some countries agreed, some countries didn't agree. Some countries said, no, the approval should be CAPI for all comers. Some countries said, no, it should just be for AKT alterations. What are your thoughts based on that data?
So first, when you look to you go to the tumor cells preclinical data, it shows that Capiva works regardless of the alteration of the pathway. So it works. It works in the wild type. Why? As I said before, there are 3 different mechanisms of resistance. So clearly, for example, HER2. So if you block the peak with everolimus or AKT, you block there, it works. So the point is that the activity in the PIK3 altered pathway is much better, it's 0.50 compared with 0.70. But if the question is, would you feel comfortable using AKT inhibitors, using Capiva in the wild type? I would say yes, I would feel comfortable. Are you going to use it? No, because I cannot. And maybe I have here the post-monarch, or I have here everolimus. I have other approaches also to be discussed. But if the question is if I would feel comfortable, absolutely yes.
Okay. Dr. Ahlam, how would you treat this patient in the second line setting?
In the second line setting, as she is the ESR1 mutation, and we agree in the beginning, we are not going to give monotherapy. For sure, I will give elacestrant, but I can add, we have Elevate trial, and there is evidence about the combination with Apema and the combination with everolimus as well. And recently, we have the combination with CAPI. We didn't mention it when we talk about the commutation. So yeah, the number of patients when they combine with CAPI was a small number. It was 31 patients only, but still it show benefit for this patient. So I think yes, elacestrant with Apema, elacestrant with everolimus is an option for me for this patient.
So Mohammed, this
Yes.
patient has an AKT alteration and an ESR1 mutation. What are you going to do for this patient? Ahlam really wants to give CAPI plus elacestrant, but she recognizes it was only 31 patients.
Yeah.
So I actually think that's the perfect combination, quite honestly. But yes, we don't have, guidelines would not allow us to do it. But Mohammed, what are you going to do for this patient?
So yeah, definitely, there is no doubt that the endocrine therapy is the backbone post-progression of the CDK4/6 inhibitors now. Unless if the patient is in visceral crisis or have CNS metastasis, then we will think about the ADC. But I think the key question here is no longer if it's endocrine therapy or chemotherapy, it's whether we will give a single monotherapy or combinations. If we already have ESR1 and AKT, I will prefer, if it's my choice and the patient has an easy access for all the drugs, I would prefer to target both pathways instead of giving monotherapy. So I will choose a CABI plus fulvestrant, which will block the SR1, and the CABI will block the AKT. If we have approval for the combinations
But we
now
don't.
that mentioned, yeah. So I will choose CABI with fulvestrant as
Okay.
291.
There's someone who's been very quiet here, and that is Sahar. She wants to say something. What does she want to do for this patient? Sahar.
Yeah, totally agree with Dr. Mohammed. I will go for the more evidence with CAPI plus fulvestrant, and I will tackle both by fulvestrant and the CAPI for the ESR1 and the CAPI for the AKT mutation. So yes, the data of Elevate is promising, but still not approved and phase two trial. So I will go for the more evidence.
Okay. So the next case is a 30-year-old lady. She had stage 3 breast cancer. She was in her 20s, actually. And she received chemo, radiation therapy, tamoxifen. She stopped tamoxifen after 2 years to have a baby. Post-delivery, she restarted her tamoxifen, but unfortunately, she relapsed 1 year later with extensive bone metastases. Tissue profiling was done because that's what I do for everyone. And I found
Yeah.
that she had a PIK3CA mutation and a germline BRCA. I need to ask Javier what he would do for this 30-year-old lady in that first line setting. He has all this information.
Patient with progressive disease on adjuvant tamoxifen, probably. So I would go for here. I would go for fulvestrant, palbo, and inavolisib, of course, plus Zoladex, plus goserelin. I would go for a triplet here.
So I have to
Yes.
ask you something here, Javier, with regards to the INAVO study. I think there's no doubt in everybody's mind it's practice changing, it is associated with an overall survival advantage. But I have two questions with regard to INAVO protocol. Number one, do we know that in patients, because a lot of these patients in INAVO actually received tamoxifen, it looked like that group of patients actually benefited the most with the triplet therapy. Do we have any idea whether if we did CDK4/6 plus an AI followed by blocking the PIK3CA pathway, would it be the same in terms of an overall survival advantage? We don't have that data. It's not been shown. And my second question is the DFS. Is the DFS of a patient who relapses at 2 years of endocrine therapy the same as a patient who relapses at, say, 9 years? Because a lot of us are giving 10 years of endocrine therapy. So does everyone need triplet therapy, whether it's 2 years, whether it's 9 years? So these are my two questions for you, Javier.
I don't have an answer, Shaheenah. I think that once again, the questions are lovely. So I'm sure that these are completely different patient populations, patients who are truly resistant or like this 2 years or 1 year. Wow, P3CA is playing a major role. Let's block it as soon as
Exactly.
possible because this patient will die quickly. And the other way around. However, if the patient is on 9 years with letrozole because they have millions of lymph nodes, and she has one lung metastasis afterwards. This behavior is totally different. So the question here is very well taken. What is better, to start with CDK and maybe afterwards go for Capiva or whatever, or start from the very beginning with inavolisib? We don't have the answer. Based on the overall survival advantage, it's so clear that it's difficult to suggest not to use it. But the question is very well taken, and I think that could be patient. But this is a patient by patient discussion. I don't have a clear answer.
Okay, so, but does everyone agree? Dr. Ram, do you agree that this patient should get an INAVO type protocol?
Yeah, I just wanted to also ask you as well as professor that in this situation, are there any studies where PARP inhibitors are combined with CDK4/6 inhibitors? Because we
I
do
would
see.
not do that. The toxicity
No,
would be
I
quite a
wouldn't
bit.
do it. But are there any studies looking at that? That's what I'm asking. Yeah.
So I let Javier answer, but I do know of some data that has looked at the combination of PARP and a CDK4/6, and it was discontinued very quickly because of the fact that it caused a lot of myelosuppression, and the toxicity was huge. So nobody, at least in my mind, would combine the two, but I leave it to Javier because he's the bigger expert in this. You can unmute yourself, Javier, to answer this.
I was laughing at you because you always go to the point, you know. So, which is the exact question now? Because it's so complex. The exact question is
Can we combine
combined.
PARP
Yeah,
and
yeah.
CDK4/6?
I understood well then. Um, no, I wouldn't combine. I wouldn't combine. I think that, you know, I think that germinal BRCA mutations are clearly a target for PARP inhibitors, PIK3CA for the PIK3CA inhibitors. However, we do not know if combining both drugs will have greater activity than the sequencing here. So based that we can sequence these strategies, I don't think that doing it together is going to be much better than sequencing these two drugs. No, I wouldn't combine.
I think, Dr. Ram, I don't think it's the combination here that I agree completely with Javier. I think you need to target them individually. My only thing about this case is I would strongly support Inavo here for a number of reasons. One, this is a very young lady who relapsed very, very quickly, although she wasn't optimized for her endocrine therapy, as you can see in the adjuvant setting. But more importantly, we do have a lot of data that's emerging, both real world data sets as well as some smaller studies that have shown that in patients who do have a germline BRCA, they don't do as well with a CDK4/6 inhibitor. So you need something extra. And so I think the triplet therapy, that's something extra for me. I would monitor the patient very, very carefully because she's going to progress very quickly, this lady. And that's where I probably would target. But yes, Javier, please.
Make comments, Shaheenah, because you raised a very critical point. And this seems to be even higher for BRCA2 than for BRCA1.
Yes.
For BRCA2, there is a clear mechanism of resistance to CDK4 and 6 inhibitors. So, but you made a great point. So let's imagine that this patient does not have a mutation in PIK3CA. Okay, and it's BRCA. So here, your point is very, very, very well taken. Is it better to go for letrozole or whatever the endocrine therapy is plus CDK, or going for the BRCA? Here, I would optimize BRCA. Here, I would prefer to go for olaparib first and after CDK. But in the PIK3CA mutant population, I would prioritize the triplet.
Absolutely. So this is another case. She's a 45-year-old lady, stage 2 breast cancer. She's had her chemo, her surgery, her tamoxifen. She's completed 5 years, 2 years post completion of 5 years of endocrine therapy. She now has extensive liver metastases. So I'm just saying to everyone, she does not fit in Inavo protocol over here. Extensive liver mets. She has CDK4, she's given CDK4/6 AI plus ovarian function suppression. Her PFS is 9 months. So she didn't actually do that well. She has progression in the liver. She's not in crisis. And you can see this can't be my patient because she wasn't profiled up front. She was profiled at the time of progression. And at the time of progression, liquid biopsy was done. She has a PIK3CA mutant disease, but baseline, she had HER2 low disease. The question now is, what are you going to do? Are you going to target the PIK3CA pathway, or are you going to do TDXD? I can see that Javier's head is like bobbing up and down and he really wants to say something. So let's ask you first, Javier, before we go on to Dr. Bennini.
She had extensive liver metastasis at
But she's not in crisis. She's not in crisis, Javier.
Yeah.
I know, but it's extensive. Why I'm saying this? Because if she had 1 or 2 liver mets, PFS 9 months, increased, and now she had 3 or 4, why not to go for PIK3CA? However, she had extensive liver metastasis at the very beginning, and now progressive disease. I would prefer to go for TDXD here and revisit capivasertib afterwards. But here, with extensive liver metastasis at the very beginning and progressive disease now, I prefer the chemo setting in HER2, TDXD, and going back certainly to capiva in the second line setting. Why not?
Okay. Dr. Bennini, what are your thoughts here?
I totally agree with Javier because this patient has only a PFS of 9 months with CDK4/6 inhibitor OFS and aromatase inhibitor. And my practice, I'm used to see a patient to consider really sensitive to have more than a year and a half and 2 years. These are the patients where I could go safely and very easily without problem to a second line hormone therapy, because the expected response rate that I will expect with only a PIK3 with capivasertib or with other hormone therapy is really less. So I would prefer to. This is my chance to get the Enhertu in the field. Yeah.
All right. So let's go on to the next case. This is a 60-year-old lady. She's got no comorbidities. She presents with stage 4 de novo breast cancer. Profiling is done, and I'll show you that in a minute. And profiling is done, and she receives a CDK4/6 inhibitor and an AI, and this time her PFS is 4 years. So she's got, in my opinion, still endocrine sensitive disease. Progression is in the bones, but it is extensive. She did not progress in her viscera. A liquid biopsy is done, and she's got an ESR1 mutation. Question is, how do you treat? Sahar.
Yeah. I think this case is candidate for the single agent endocrine therapy. Being stayed for a long time on CDK4/6 inhibitor, even with progression, only progressed in bone. So I can consider the Emerald, elacestrant, or other oral third like imlunestrant or even camizestrant. So I can proceed for single agent endocrine therapy if I have the access to any one of them.
So, Javier, let me put it this way, and I'm going to ask you two questions over here. One is, and I'm a very strong believer in combination, irrespective of the PFS. And this lady has a PFS of 4 years, but in my mind, extensive bone metastases progression is just as bad as it going into the viscera, because I've seen patients actually do badly there as well. So for me, I would use an oral SERD, but I would use it in combination and not alone. So I want you to comment on that. That's question number 1. Question number 2, what if this patient also had a PIK3CA mutation? In addition to an ESR1 mutation, her PFS is 4 years.
So basically, I agree with the previous comment. I completely agree. I think that this application for an oral SERD, she was 4 years on with a PFS of 4 years. So maybe the ESR1 mutation is now driven or driving the resistance, makes a lot of sense. So first comment, would I combine elacestrant or whatever drug is with? Of course, if I could, I would.
Yeah.
Okay.
I wouldn't do it imlunestrant plus abema. I think that trial was not ethical, okay? Because some patients received imlunestrant alone in the second line, and this patient did not receive CDK4 and 6 inhibitors, nor in the first line, nor in the second line. So I would never use imlunestrant abema, never. But I would like to combine elacestrant plus capiva, elacestrant plus everolimus. Sure, that's something that I would love to do. And you know that we are running the Adela study, which is elacestrant with or without everolimus. Now, if I would have a double mutation here, I wouldn't change my mind. I think that this is a patient who is progressing, late in time. That means, in my opinion, that the PIK3CA is not a clear driver of the resistance, because the PIK3CA was there at the very beginning.
Yes.
And the patient did very nicely with endocrine therapy. So I would prioritize here the ESR1.
Okay. Let's go on to the next case. This is a 40-year-old lady, stage 4 de novo with lung nodules. She was treated at a different institution, and she was actually treated with curative intent, because I think at the time of presentation, she had 2 lung nodules that were very, very tiny. And so they said, okay, let us treat her with curative intent. So she got chemo, surgery, radiation therapy, and she had an oophorectomy as well. And she was put on letrozole for 7 years. At 7 years, she had progression of disease. She'd actually come to our hospital, and she had shortness of breath. She had a cough. It wasn't that extensive, her lung mets, but it was causing compression of, she had lymph nodes also in the mediastinum that was causing compression. That was what's causing her cough and her shortness of breath. Biopsy was done. It's an ERPR positive, HER2 low disease. She has no disease anywhere else. We did send her tissue for profiling. However, at this point, I won't tell you what the results were. I'm going to ask Ahlam, what would you do in this particular patient?
Yeah, this patient, we didn't confirm in the beginning that the lung was metastasis.
No, it was
But we can-
metastatic. It was metastatic. She had been treated at a different institution. It was metastatic.
Yeah.
On PET, it was FDG avid. She had a biopsy that was proven, but it was only 2 lung nodules. So they decided to treat her with curative intent.
Curative intent, and she did
But it was
very well
stage 4
with
de novo.
yeah, okay. Then, but she didn't receive the CDK4/6 inhibitor.
She did not, which was
She stayed,
surprising,
yeah,
actually.
yeah,
Yes.
yeah. So yeah, I think she deserved to be in the first line. I think if she stayed for 7 years in the letrozole only, she had a good chance to stay a good time in the CDK4/6 inhibitor with the other endocrine therapy. And I have one patient who started with other oncologists who received letrozole for years, but that patient was confirmed metastatic. And when she progressed, I started her on CDK4/6 inhibitor with other endocrine therapy, and she stayed for 3 years as well. So I think, yes, I will treat her like this. I will add CDK4/6 inhibitor and I will use other endocrine therapy.
So Javier, let me make this complex for you and tell you what the profiling actually showed. It showed she had a PIK3CA mutation. It showed she had an ESR1 mutation because 7 years she was on an aromatase inhibitor. So my question to you is, I think you have 3 options. Option number 1 is to add a CDK4/6 inhibitor here to her letrozole, something similar to what we've seen in prior, like the trend study where they just added the CDK4/6. Second option is to change to fulvestrant plus a CDK4/6. Third option is to target the ESR1 mutation that has developed with an oral SERD plus combination. So you could add a CDK4/6, and just to throw it in the mix, she was treated with potential curative intent. So could she be INAVO candidate?
Agree. I think, okay, so this is a patient with a double mutation, PIK3CA and ESR1. So I don't think that PIK3CA here is a driver. I agree, maybe not, because 7 years is a lot. Nevertheless, because this is a patient who did not receive CDK4/6 inhibitor, this is clearly the most important partner, in my opinion. So fulvestrant and CDK is the driver. Now, because this patient has a mutation in PIK3CA and we have data coming from INAVO 120 in the adjuvant setting, first line, this mimics a little bit that first line of. So I think I feel very comfortable with INAVO 120 here. I would go for fulvestrant, palbo, and INAVO.
Okay, Mohammed, what are your thoughts over here?
So I believe I agree totally with Dr. Cortes. I believe PIK3 is not the driving mutations here who cause progression. So CDK4/6 inhibitor plus fulvestrant in the meantime is the best option. I believe if later on more result came with the Electra trial that was showing abemaciclib with elacestrant and it's approved, I think it will be a very good option in this case. But until that time, CDK4 with fulvestrant, my first option.
So I gave her a NAVO protocol just to let you know, and she responded beautifully, and she continues to do well. Just to let you know that that's what I did. All right. So, okay. So, and we've already discussed this. So this is the same case, but we've changed it around a little bit. Let's assume that she got a CDK4/6 inhibitor plus letrozole, and her PFS was 2 years. She had progression in her lung. This is again hypothetical because I gave this lady INAVO. And the tissue showed an AKT alteration. So now what would you do, Ahlam?
Yeah, this patient, she had an AKT alteration and she stayed for 2 years. And now the lung progression, yes, I can add the CAPI with fulvestrant.
Okay.
This will be a good option for her, yes.
Okay,
And I hope
perfect.
that we will see good results, yes.
So this is a very interesting case. She's 45 years old, married, no children. She's a housewife. She was diagnosed with stage 2 high-risk breast cancer, ER-PR positive, HER2 low. Oncotype was 45. She declined chemotherapy. She received radiation therapy. She got an AI plus Zoladex, which she started and then stopped because she was completely intolerant to it. She received tamoxifen for a few months and then decided she didn't want to take it anymore because I can tell you this woman was completely not wanting any type of endocrine therapy. Unfortunately, DFS of 2 years then had bone recurrence. She was then commenced on ovarian function suppression, AI plus abemaciclib. Her tolerance to abemaciclib was so poor, she kept ending up in the emergency. Like I'd never seen someone having such poor tolerance to abema. And the AI was also a very, very poor tolerance, and she kept stopping it. Eventually, the disease progressed in her bone to an extent she started cracking her bone because she had a lot of bone pain and she required radiation therapy everywhere. At this point, she shifted institutions and she came to see me. And I can tell you, with all the poor, tolerance and everything, she had a PFS of approximately 6 months. I would not even call it 6 months because she just didn't do well and she was not taking her therapy. I did a liquid biopsy and she had a PIK3CA mutation and an ESR1 mutation. Javier, what would you do for a patient like this?
So let me add something, because a patient tolerated abema very badly, but do you try to maybe to look at a palbo, ribo, or
So she got palbo as well. I didn't mention it over here, and she just was not tolerating anything. I can tell you that.
so I think that this is a patient with primary resistance, very bad prognosis. She does not have a significant amount of disease, no visceral metastasis. For me, is clearly a patient that I would prioritize to Capiva. Why not? I would try to block PIK3CA. I would go for fulvestrant. I would give another chance of endocrine therapy before moving into the chemo setting. I would go for Capiva.
So, Dr. Ram, what would you do over here?
Yes, I think that's very much, I would say the first choice here, fulvestrant plus Capiva. But only I will be, because the side effect profile for Abema and Capiva is sometimes diarrhea is there, maybe the percentage is different. So I would like to find out more details about what was the intolerance she had.
Her
Do a good
intolerance?
education, do
Yeah.
a good education to the patient and try to do prophylactically and follow up very closely the first 1 month so that she will not discontinue the treatment. This lady
100%.
clearly needs a lot of education and a lot of engagement
So,
in her treatments. Yes.
I can tell you, I have never educated a patient as much as I educated this one. And
Mhm.
the AI, she could not tolerate it.
Mhm.
The CDK4/6 inhibitor, she could not tolerate it. At one point, she would tell me she can't even get out of the bed. And she was admitted so many times to the emergency. And I think compliance also was a huge issue. Interestingly, when I saw this on the liquid biopsy, I decided to actually want to give her TDXD, but there was no way for me to give her anything orally or, and to ensure compliance. She declined TDXD because she was not willing to get any form of chemotherapy. You can imagine oncotype DX of 45. She just didn't, she was saying, I'm not getting any chemotherapy. So I then decided to give her Capi plus fulvestrant. With the fulvestrant, I was able to monitor, and so she was able to come in and get her fulvestrant. So I was able to stick that needle into her. She tolerated the Capi really, really well at full dose. No hyperglycemia, no mucositis, no nothing. This patient has now been on Capi and fulvestrant for a solid 1 year and is in complete remission. Complete remission. So again, I was very, very impressed with this case. That's why I brought it here. That sometimes, we may think that everyone does badly when they relapse very quickly. But some of these patients actually do very well, and I'd like to call to your attention the real world data and the subgroup analysis that's actually come out from Capitello. The earlier you use Capi, the bigger your benefit. And I think we used it very early here. We didn't extend her, non-compliance to everything. So again, I thought we did very well with giving her Cappy plus fulvestrant over here. And that was the last case. We're at the top of the hour. I think this has been a very interesting 1.5 hour. Javier, you were amazing as always. You walked us through everything. And thank you for being a sport for every one of those difficult questions that I threw at you. Sahar, Mohammed, Ahlam, Ram, and Dr. Bennini, thank you all for being part of this edition of the EIOC Journal Club. You've all been amazing. And I hope to see you all at the next edition of EIOC Journal Club. Just to let you know, Javier is having a good vacation in Milan at the next Milan Breast Symposium. So please enjoy yourself there, and I'll see you all at a later date. Thank you very much.
Bye-bye.
Thank
Okay,
you. Thank you,
thank
Dr.
you.
Shaheenah.
Bye-bye.
Thank
Thank you
you.
very much, everyone.
Bye.
Good night.
Bye. Bye. Bye.
Thank
Thank
you.
you. Bye-bye.